Thank you, Dr. Mahmoud and Dr. Ahmed, for the kind invitation. So actually, we are talking today about mainly the aortic arch pathologies and what are the options of treatment. Uh, okay, is it working? Okay, so we all know that aortic arch aneurysm represents only about 10% of the aortic pathologies. As well, we know that it is a high-risk surgical challenge despite all the advances in the surgical and anesthetic management and techniques, and still it's a complex challenge even with the endovascular procedures. Luckily, we recently, in 2019, had this important paper from ESVS and the European Association of Cardiothoracic Surgery about some guidelines or a blueprint of how to deal with aortic arch pathologies. First of all, we have to emphasize the role of aortic team in managing those patients, and as well as the role of centralization in high volume centers to manage those pathologies. Starting talking about dissection on those patients, so we had Stanford and the Baker classification for a long time, but unfortunately we always missed talking about the dissection starting from the arch, not from the ascending aorta, and that's why necessitated evolution of term non-A, non-B, or even C now, and sometimes about this type of dissection, which representing about 11% of patients with acute aortic dissection. And the clinical presentation treatment outcome is totally different in those cohort of patients, and the involvement of arch in the dissection paramountly impacting the clinical course and outcome. We're moving to intramural hematoma as another pathology. We have a lot of definitions from ESVS and ESC, but the important thing that with the more sophisticated imaging we have in hand now, we can identify more and more primary entry tears, which could be considered as precursor for acute aortic dissection. And there are some predictives from the paper I mentioned about with or without having ulcer or intimal erosion that can give us indication of the progression of this intramural hematoma to a more serious event, especially if the involvement of the ascending aorta or with increasing size of the aorta or pleural effusion, chest pain, ulceration of the ascending aorta, and of course the diameters of those lesions. Moving to penetrating aortic ulcer as another modality of the pathologies we are facing in this region, we found that 27% of those of patients with acute aortic syndrome has penetrating aortic ulcers, and again indication for intervention including pain, contained rupture, rapid growth, hematoma, and especially there is mentioning about the depth and diameter of ulcers in those patients and when to intervene. Talking about the management plans we have, of course we have the open surgery for a long time with hemi-arch surgery, with elephant trunk, and now even the frozen elephant trunk is potentially indicated in all those pathologies and giving a space or a window for endovascular completion in the future. But I think now we are moving more towards hybrid and endovascular era, which, first of all, the hybrid management, we all know the principles is to exclude the pathology and create an adequate proximal landing zone in zone 0, 1, and 2 for our endovascular graft through doing deep branching. And the potential advantage of this, of course, is to avoid hypothermic circulatory arrest, cross-clamping, and cardiopulmonary bypass in those high-risk patients. But still, the spinal cord ischemia is a big challenge, especially when we are covering a long segment of the descending thoracic aorta. That's why we have always to consider CSF drainage perioperatively, especially with patients with previous aortic surgery, left subclavian or interiliac lesion or disease. We have evolving evidence that TVAR in zone 0 after previous debranching may be considered in those patients, especially if they are unfit, and as well TVAR in zone 1 and 2 should be considered in those patients if you have suitable anatomy. Now we are moving to actually to in the endovascular era, I mean, which mitigated the risk much from open surgery for those high-risk patients. And of course, it needs certain criteria, including stable proximal landing zone with diameter of the ascending aorta or the graft, native graft after Pental operation or any previous operation to 38 millimeter or less. And we have to be generous in choosing our proximal landing zone. Sometimes we talk about 3 centimeter off on the inner curve. We're free of calcium or thrombus to have a proper seal and durable repair for those patients. Still, stroke is the main concern we are dealing with, and some reports even report about 14% risk. And the mechanism still is either solid emboli during the wires manipulation in the arch or air emboli from the system. And to minimize this risk, we have many measures like temporary carotid occlusion, filter placement, carbon dioxide flushing, and all other things. At the present, we have to be very careful about the patient selection for those techniques, and we have to, as we mentioned before, it should be centralized to have a good learning curve and high volume centers. And of course, we have again growing evidence that endovascular aortic arch repair in zone 0 and 1 should be considered in patients that are unfit for open surgery. I'll go through some cases we did. So the first case was a young patient in his 40s coming morphanoid with dissection starting from the arch, and he had uncontrolled hypertension and intractable chest pain. So we had to go, we did hybrid technique in this one. So my cardiothoracic colleagues did the thoracotomy. I did a bypass from ascending aorta, bifurcate graft from ascending aorta to innominate and left carotid. And in the neck, we did carotid subclavian bypass, and we placed TVAR. And after 6 months, he had transitional monoplasia in his left leg for about 3 weeks that improved markedly by physiotherapy, but he recovered well, and after 6 months there was good false lumen. Oh, sorry, can you play this video, please? So he had significant false lumen remodeling, and no endoleak from his aorta. Sorry, from the endovascular graft. Okay, next, please. Sorry, next slide. Back to slides. The second case was a frail old gentleman with a lot of comorbidities. He presented with symptomatic arch aneurysm, about 8 centimeter, which necessitated again debranching with carotid bypass and TVAR. And this gentleman, he had initially good recovery, but unfortunately he had multiple admissions in the first. Can you go to the next slide, please? Can we go to the next slide, please? So we managed to do debranching in the neck with carotid bypass and then TVAR. As I mentioned, he recovered well. He left the hospital, but he had recurrent admissions, and at the end he didn't survive. The 6-month follow-up scan was very reassuring with no endoleak from his TVAR, but he died after 9 months. The third case is a lady, again with the previous TVAR for trauma from blunt thoracic aortic trauma, but she presented to our center with hemoptysis, and when they did the CT scan, they found there is a migration of the graft and the type 1A endoleak with aortoesophageal fistula. So again, we managed to do a hybrid procedure with carotid bypass and TVAR. Can we go to the next slide, please? So again, a hybrid procedure with debranching and TVAR, and she recovered well from this, and 6 and 9 months follow-up CT scan shows no endoleak, and proper seal. I think there are some technical problems with the videos. Okay, can we go to the next slide? Okay, this is the follow-up CT scan. Okay, next, please. The fourth case was a frail lady with very long aneurysm starting from the arch to the diaphragm. In this case, she was very unfit, so we thought that we will go for total endovascular repair. So we chose to use a relay plus graft. Can we go to the next slide? With a scallop to the left carotid artery and branch to the left subclavian artery. And can we go to the next slide? Next slide, please. Yeah, so that was the planning with the relay plus graft. So we did a scallop to the left carotid and left subclavian artery branch with using a Viaband stent. And next slide. Okay, can you play the video, please? And that was the final angiogram from the procedure. Thank you. Next slide, please. And that was a 6 months follow-up CT scan after showing no endo leak and patent Viaband stent to the left subclavian and patent scallop. So that was good success. This is actually an interesting case. So this is in process. So this lady started with intramural hematoma to the zone 1 to 2, and she developed dissection in this place and with multiple episodes of chest pain that makes her comes regularly to the A&E department. And we thought that we will go for full endovascular repair.
For the time, because I think we are behind the time.
10 seconds, yes, thank you. And we are planning to go for full, well, hopefully we are waiting for the custom-made device to be with us in the next couple of weeks with 3 branches to go for full repair, endovascular repair. So take-home message that those cases need to be done through an aortic team in high-volume centers. MDT case-by-case discussion is mandatory, and definitely we need more long-term results and to build our further evidence. Thank you.